Okay, let's unpack this. We're diving deep today into some of the, well, frankly, fascinating and sometimes really perplexing data that came out of the COVID-19 pandemic, especially around the vaccines. You've brought us a really comprehensive stack of sources here.
Huh.
We've got published research, public health reports, news articles, even your own notes. And our mission today, like always, is to pull out the most important nuggets of knowledge. We really want you to walk away from this deep dive feeling truly well informed, not just knowing the facts, but understanding the nuance, the context that often gets lost in the headlines, you know? So today we're going to tackle some pretty big questions, questions that really challenged how people saw things and sparked a lot of debate. How did we end up with statistics that, well, on the surface anyway, seem to completely contradict the very strong messages we were hearing about vaccine effectiveness? And what does it actually mean when public health data gets really complex, or maybe even looks confusing, contradictory? And maybe the biggest question, what can we learn from this whole period about how we, interpret information, how science gets communicated, and how we gear up for future challenges? So, get ready. There might be some surprising facts, maybe a few aha moments, and hopefully a much deeper grasp of the incredible complexities behind those numbers. The initial paradox. A closer look at 2021 mortality data. Okay, so let's start our journey into this paradox. There's this one specific statistic that, when it first came out, really grabbed the media's attention back in 2021. And for a lot of people, it immediately sparked confusion, maybe even some real concern. It was a report that between May and June 2021, something like 60% of COVID-19 deaths were actually among people who were fully vaccinated. Now, just hearing that number raw, it's jarring, right? It seems to fly right in the face of the whole idea of vaccine protection that health authorities were pushing so hard.
Absolutely. And what's really fascinating here and what caused so much public, well, consternation is how that single number, which was accurate, technically, within its very narrow, specific time frame and context, created such a huge, often really misleading public reaction.
Yeah.
It wasn't just confusion. It led directly to some pretty pointed questions, a lot of skepticism. We saw figures like U.S. Representative Roger Williams kind of highlighting this paradox. He even pointed out that based on Johns Hopkins data, more people actually died from COVID-19 in 2021 than died in 2020.
Wow.
Yeah, and that statistic, the one about the higher overall death toll in the second year, despite vaccines being widely available, just amplify that really critical question. If these vaccines were out there, if they were developed at incredible speed, and if they were supposed to be so effective at preventing severe disease and death,
Hmm.
why did the death toll in 2021 actually go up?
It seems completely backwards.
Exactly. Totally counterintuitive for a public that was just desperate for a clear end to the whole crisis.
That really is the core of the paradox, isn't it? You had these incredible scientific achievements. I mean, multiple vaccines developed and rolled out faster than anyone thought possible. And those early clinical trials, particularly for the mRNA vaccines like Pfizer and Moderna, showed amazing efficacy rates, like upwards of 94, 95% against symptomatic infection. The hope was just enormous.
Hmm.
But then the raw numbers coming out of the real world seem to tell this different, much more troubling story. It really threw that idea of complete protection into question, an idea that maybe some people had assumed the vaccines offered. The realization that vaccinated people could still get COVID, could still get seriously ill, and yes, tragically, could still die from it, that definitely caught many people off guard. Especially when so much of the initial public health messaging really hammered home vaccination as the key to getting back to normal.
Indeed. And this phenomenon, it created a really visible, sometimes quite angry divide in public opinion. For some people, maybe those already a bit wary of government or pharmaceutical companies, this data seemed to fuel their existing skepticism. It looked like validation for their concerns.
Right.
For others, though, it highlighted maybe a profound misunderstanding. Not necessarily about how these specific vaccines work, but maybe about how any vaccine works during a fast-moving, real-world pandemic with an evolving virus. It wasn't that the vaccines were useless, far from it. It was more about the really complex context surrounding those breakthrough deaths and maybe how effectively or ineffectively that context was being communicated, especially to a public that understandably wanted simple answers.
Yeah, simple answers in a complex situation are hard to come by.
Exactly. It just underscored this incredibly delicate balancing act you need when communicating complex, changing health statistics during a crisis. A single number, taken out of context, could have this massive impact on public trust and ultimately public behavior. 2. Unpacking the context. Why 2021 was different.
Okay, so what does it all mean then? How do we square that shocking 60% figure, or the fact that more people died overall in 2021, with the undeniable science behind the vaccines? Like you said, the numbers alone clearly don't tell the whole story. In fact, they can be deeply misleading if you don't have the full picture. So to really get our heads around this paradox, we need to kind of peel back the layers, right? Dig into the crucial interconnected factors that basically changed the whole game in 2021, even while millions were getting vaccinated. These are like the critical missing pieces of the puzzle.
You're absolutely right. It's not a simple equation at all. If we connect this to the bigger picture, there were several really powerful factors all playing out at once, dramatically shifting the pandemic's dynamics. They made 2021 fundamentally different from 2020. First, you could argue this was the most pivotal change, was the emergence and then dominance of new, highly transmissible variants.
Ah, yes, the variants.
Yes, exactly. Early in 2021, we saw Alpha rise quickly. Then came Delta in mid-2021, which was a huge deal. And later, towards the end of the year, Omicron hit. These weren't just slightly different strains, they were game changers. Delta, for instance, was found to be way more contagious than the earlier versions, sometimes doubling or even tripling how fast it spread.
Wow.
So just the sheer volume of cases exploded. Even with vaccination, that meant more people were getting infected overall, just mathematically. And what's more, these variants, especially Delta and later Omicron, showed some ability to partially evade the immunity provided by the initial vaccines, particularly against getting infected at all, though generally less so against getting severely ill.
Okay, so protection against severe disease held up better.
Generally, yes. That was the key finding. While the vaccines weren't this perfect shield against any infection that some might have hoped for, they were still largely effective at preventing the worst outcomes. But this partial immune escape led to a huge number of breakthrough cases. And unfortunately, because the sheer number of infections was so high, that translated into more hospitalizations and deaths among both vaccinated and unvaccinated people. It's a major reason why the hope for a really sharp, immediate drop in deaths after vaccination wasn't fully realized. The virus itself evolved, forcing us to constantly adapt our public health response and reevaluate how the vaccines were performing in this new, dynamic environment.
So it was almost like the virus kept learning and finding ways around our defenses, even as we rolled them out. We were constantly playing catch up.
That's a good way to put it. And making that challenge even harder was this persistent and really significant issue we faced all through 2021. The challenge of vaccine hesitancy and also unequal vaccine uptake.
Right, not everyone got vaccinated or got vaccinated at the same time.
Exactly. Even though vaccines became widely available by mid-2021 in many wealthier countries, a really substantial chunk of the population remained unvaccinated. And this hesitancy wasn't simple. It was driven by a whole mix of things. Some people had genuine concerns about how new the vaccines were or how fast they were developed.
Sure, that's understandable.
Others were influenced by misinformation or disinformation spreading online. Some had deep-seated distrust in public health institutions or the government. And for some, maybe it was just a feeling that it wasn't that urgent for them or they didn't perceive the risk as high. This patchwork uptake created this ongoing pathway for the virus to just keep spreading, especially hitting vulnerable groups, hard people who maybe couldn't get the vaccine easily due to access issues, or those who chose not to for their own reasons.
So it left gaps in the collective defense.
Precisely. The societal impact was huge. It allowed the virus to keep finding places to spread and mutate, keeping the pressure on healthcare systems even as national vaccination rates were climbing. It created these pockets of high susceptibility where outbreaks could just flare up, straining local hospitals and clinics.
And it wasn't just about vaccines or the virus changing, was it? There was also this general sense of exhaustion, a shift in how people felt about the whole thing.
Oh, absolutely. You cannot underestimate the impact of public fatigue and just shifting perceptions of the threat. Think about it. Prolonged lockdowns, mask mandates, social distancing. While they were definitely effective, especially early on, they led to what experts call compliance fatigue.
People were just worn out.
Completely worn out. Tired of the rules, tired of the uncertainty, tired of being constantly on guard. As 2021 dragged on, you saw many people starting to treat COVID more like an endemic problem, something we just have to live with, maybe like the flu, rather than an acute, immediate crisis needing emergency measures.
That's a big mental shift.
It is. And this shift, often amplified by social media narratives that maybe downplayed the virus's severity or constantly questioned the public health rules, led to less adherence to safety protocols. Imagine running a marathon, but the finish line keeps getting pushed further away, and everyone around you is just collapsing from exhaustion and frustration. Public resolve just naturally wore down. That made collective action much harder.
So more social interaction, maybe less caution?
Exactly. More gatherings, less consistent mask wearing, fewer precautions overall. all of which just gave the virus more chances to spread, especially the more contagious variants.
And all of this evolving virus, the vaccine hesitancy, the public fatigue, it was all happening while our healthcare workers who'd already been through so much in 2020 were just being pushed beyond their limits.
That is an absolutely critical point. The final and deeply impactful factor was the continued severe strain on overwhelmed healthcare systems. Hospitals faced just unprecedented pressure throughout 2021. Wave after wave of cases, driven by the new variants and ongoing spread among the unvaccinated. Resources, ICU beds, ventilators, PPE, everything were stretched incredibly thin. But maybe most critically, the human resources. Healthcare providers were dealing with immense burnout, physical and emotional.
I can only imagine.
It led to staffing shortages, a real crisis of morale. And this strain, it didn't just impact COVID patients, whose care might have suffered due to packed wards and exhausted staff. It also hit people with other serious medical conditions needing urgent care.
Right, because the system was clogged.
Totally. Routine surgeries got postponed, emergency rooms were overflowing, access to essential non-COVID care went down. This just worsened the overall health crisis, indirectly adding to the higher mortality figures because the system's ability to provide the best care for everyone was compromised. It really paints this picture of frontline workers fighting this incredibly difficult battle against an evolving virus, against widespread public weariness, and often within a politically charged, divided public landscape. 3. The shifting sands of data reporting and public trust.
Okay, here's where things get really interesting and, frankly, pretty controversial, too. Right around the time these, let's say, unsettling statistics about vaccinated deaths started getting a lot of media play, like that 60% figure from May, June 2021. We mentioned the CDC, the Centers for Disease Control and Prevention, made a pretty significant change to how they were reporting data. And this decision, it immediately sparked controversy. It led to widespread accusations about a lack of transparency, and some people felt it was even an attempt to hide information.
This specific moment really puts a spotlight on a tough question. What is the role and responsibility of public health authorities during a long, drawn-out crisis like this? Critics, pointing to various sources and their own interpretations, argued really strongly that stopping the regular detailed reporting of deaths, specifically among vaccinated people, could easily be seen as intentionally hiding data.
That's a serious accusation.
It is. They saw it as the CDC actively concealing information from the public. And regardless of the actual reason behind the change, that perception inevitably damaged public trust in the vaccination campaigns. For people who are already skeptical about the vaccines or maybe distrustful of government messages, this shift seemed to confirm their worst fears. It fueled narratives about a deliberate cover-up, making it even harder for public health messages to cut through effectively.
So that's one side. Deep concerns about transparency, the feeling that data was being hidden. But there was another perspective on this, wasn't there? It wasn't necessarily framed as hiding data by those who supported the change.
Absolutely. There was a counter-argument. Supporters of the CDC's decision argued that the public health focus should shift away from isolated, potentially misleading raw numbers, like that 60% figure, and towards broader trends that show the overall effectiveness of vaccines, particularly in reducing severe outcomes.
Focusing on the big picture benefit.
Exactly. They emphasized looking at how vaccines were preventing severe illness, hospitalization, and death across the whole population, rather than getting fixated on the relatively small number of breakthrough cases. They argued that constantly highlighting individual breakthrough deaths, which, let's be honest, were always going to happen in a massive pandemic, with a highly contagious virus and evolving variants, could be deeply misleading without the right statistical context, without understanding population dynamics.
Because the denominator matters the total number of vaccinated people.
Precisely. And the baseline risks in different groups. They also pointed out that this shift in reporting reflected the growing reality of widespread natural immunity from prior infections, and just a more mature understanding of how vaccine efficacy evolves over time and against new variants. It wasn't the same simple picture as in the initial clinical trials. The argument was essentially that the main public health message needed to be about the core, sustained benefit avoiding the worst outcomes, rather than getting bogged down in numbers that could be easily misinterpreted. Numbers that could potentially increase vaccine hesitancy by creating this false impression that the vaccines weren't working well.
So it was a strategic communication decision, in a way, trying to balance providing data with preventing negative public health consequences from misinterpretation.
You could definitely see it that way. It became this incredibly difficult balancing act. How do you provide granular data that some demand, but which can be taken out of context and misused, versus providing broader, more contextualized data that maybe better reflects the vaccine's primary public health benefit.
And we saw public health leaders grappling with this. I remember then CDC Director Dr. Rochelle Walensky talking about the need to keep monitoring breakthrough cases, but also emphasizing the importance of population-level data to show the big picture of vaccine effectiveness. Dr. Fauci often made similar points, stressing context.
Precisely. It just highlights the immense complexity and, honestly, sometimes the no-win situation of public health messaging in a fast-moving crisis. The decision to shift focus away from granular breakthrough death reporting, even if the stated goal was to prevent vaccine hesitancy and maintain public uptake, inevitably fueled distrust among some segments of the population. These discussions, even when rooted in scientific data, quickly became highly politicized, which just made rational public health discourse incredibly difficult and eroded trust in ways that, frankly, we're still dealing with today.
Yeah.
Ultimately, that careful, fraught balance between reporting every single data point accurately and maintaining public trust in health institutions, that really shaped how the pandemic was discussed and how the public reacted to the evolving guidance. It's a real case study in how information, even accurate information, can be framed and interpreted so differently, leading to vastly different outcomes on the ground. 4. Understanding vaccine effectiveness in the real world, beyond the headlines.
Okay, this brings us right to a really fundamental concept that was just central to everything. Vaccine effectiveness, or VE. What does that term actually mean beyond just a percentage? And how did our understanding of it change during the pandemic, especially when these surprising, sometimes even seemingly negative effectiveness findings started popping up? Getting this right is key to understanding that 2021 paradox.
Right. So vaccine effectiveness, VE, is defined pretty simply as the ability of a vaccine to prevent disease under real-world conditions. Not in a lab, not in a perfect clinical trial, but out here in the messy real world. It's usually expressed as a percentage. It compares how often the disease occurs in vaccinated people versus how often it occurs in unvaccinated people under those specific real-world circumstances.
So like 90% VE means vaccinated folks are 90% less likely to get the disease than unvaccinated folks.
In that specific context, yes, that's the basic idea. But while it sounds straightforward, the reality is, it's far more nuanced. It's influenced by a whole host of factors that make it a constantly moving target, not a single fixed number.
I definitely remember those early reports in 2021, like the ones from the CDC showing VE rates way up there, over 90% against symptomatic COVID for the mRNA vaccines, Pfizer and Moderna. That felt incredibly reassuring at the time. Huge protection against getting sick, getting hospitalized. It gave everyone so much hope.
Those early findings were absolutely instrumental. They came largely from those initial, very well-controlled clinical trials and some early real-world data collection. And they absolutely shaped public attitudes and drove that initial massive vaccine uptake. The message was clear and powerful. These things offer really strong protection.
However, as the pandemic wore on, and as we ran into those highly transmissible variants like Delta and then Omicron, the picture started to shift. Multiple studies, including large population-level data analyses from countries with high vaccination rates, began reporting lower VE, especially when it came to preventing just symptomatic infection.
So less protection against just getting sick, even mildly.
Exactly. Now, this wasn't necessarily a sign that the vaccines had failed. It was more a reflection of the virus evolving to partially get around the vaccine-induced immunity, at least for infection. But, and this is the crucial point, the vital context, even with that reduced protection against just getting symptoms, the vaccines generally maintained a very high degree of effectiveness against the severe outcomes.
Okay, that's the key distinction again. It is preventing severe illness, preventing hospitalization, and most importantly, preventing death. So even if you were vaccinated and unlucky enough to get infected with Delta or Omicron, your chances of ending up in the ICU or worse were still dramatically lower compared to someone who was unvaccinated.
So the goalposts kind of shifted, maybe less about stopping any infection and much more about stopping the really bad outcomes. That's a distinction that sometimes felt like it got lost in the noise.
I think you could absolutely say the goalposts shifted, or perhaps our understanding of what the vaccines could realistically achieve against an evolving target shifted. There was a really key study published in Nature early in 2022 that illustrated this perfectly. It showed that VE against just getting symptoms from the Omicron variant was considerably lower, sometimes down to the 30–40% range, compared to that 90% plus we saw against the earlier strains.
Wow, that's a big drop.
It is. And it just highlights how significantly viral evolution impacts vaccine performance over time. On top of that, As more time passed after people got their initial shots, we saw clear evidence of waning immunity. The protection wasn't lasting forever at peak levels. This natural decrease in VE, observed several months after the initial vaccination series, is what prompted the calls for booster shots. The boosters were designed specifically to kind of top up the immune response and strengthen protection, especially against the newly circulating strains.
So, not really a flaw in the original vaccine, but more about the virus changing and our own immune systems needing a reminder, like getting a flu shot every year.
That's a very good analogy. It wasn't a failure, but a reflection of viral evolution and human immunology.
And it's not just the virus evolving or time passing, right? We're not all identical. Human factors, our individual biology, our life circumstances, they must play a role too.
Oh, absolutely. You hit on another layer of complexity. The factors influencing VE aren't just about virology or time. They are significantly shaped by a whole mosaic of demographic and social determinants of health. For example, numerous studies have consistently shown that factors like age, older adults generally mount less robust immune responses, or having underlying health conditions like diabetes, obesity, or being immunocompromised, even things related to socioeconomic status, can all affect how well someone's immune system responds to a vaccine.
So, the observed effectiveness might look different in different groups of people.
Exactly. Older adults or people with weakened immune systems might show lower or less durable protection, contributing to disparities in the VE we see when we look at different population groups. And these variables, these differences between people, they absolutely must be meticulously accounted for in any analysis of VE data. If you don't adjust for these confounders, a study might wrongly attribute differences in outcomes just to vaccination status, when really it's these underlying health differences or different levels of exposure that are driving the result.
That makes sense.
Geographic variations also complicate things massively. Think about differences in access to healthcare, local virus transmission rates, the quality of healthcare infrastructure, even differences in public health messaging and local compliance. All these can shape the outcomes you observe at a particular place or population. Plus, how vaccines were rolled out, who got them first, how quickly varied enormously from place to place, further muddying the waters for observational studies. Researchers really need to consider these local contexts when they interpret data.
So it's this incredibly dynamic puzzle. You've got the virus changing, the vaccine's effects changing over time, and then huge variations in the people receiving the vaccine and the environment they live in.
Precisely. It really underscores why we need such careful, highly contextualized interpretations of vaccine effectiveness data. It's rarely just one simple number.
Yeah.
The canary in the coal mine. Biases in observational studies.
Okay, this leads us to a concept that sounds really counterintuitive. This idea of negative effectiveness, where it looks like an intervention, like a vaccine isn't working, or maybe even seems to be making things worse, when that's not actually the case. Your sources describe these findings as a kind of canary in the coal mine, a warning sign pointing to deeper problems, not necessarily with the vaccine itself, but with the research methods being used. This feels really important for understanding that 2021 paradox. Let's dig into this because these biases often seem to be the hidden culprits behind data that looks contradictory.
Indeed. And you're right, it often is the methodology. Look, observational studies are absolutely crucial in public health. We rely on them heavily, especially when doing randomized controlled trials. The gold standard just isn't feasible or ethical. Like during a rapidly spreading pandemic, you can't ethically withhold a potentially life-saving vaccine from a control group just for research purposes.
Makes sense.
But the trade-off is that these observational studies, by their nature, are susceptible to various biases that can really twist the findings. Understanding these biases is critical because if we don't account for them, we can draw completely wrong conclusions about vaccine effectiveness, which then impacts policy and public trust. Those negative effectiveness findings were often a flashing red light, signaling that one or more of these biases were likely skewing the results. So let's start with selection bias. This happens when the people included in your study aren't really representative of the broader population you want to understand. Or maybe the groups you're comparing, say, vaccinated versus unvaccinated, are fundamentally different in ways that affect the outcome, besides just their vaccination status.
Give me an example of how that might play out with COVID vaccines.
Okay, think about the early vaccine rollout. Who got vaccinated first? Often it was healthcare workers, older adults, people with pre-existing conditions. They were prioritized because they were at higher risk or had more exposure. Now imagine a study comparing the health outcomes of this early vaccinated high-risk group to a group of younger, healthier, unvaccinated people who either weren't eligible yet or chose not to get the vaccine.
Okay.
If you just compare those two groups directly, the vaccinated group might actually look like they have worse outcomes, maybe even higher mortality rates for all causes, simply because they started off much sicker or older. The analysis might wrongly suggest low or even negative VE because you're comparing apples and oranges. The vaccinated group had a higher baseline risk before they even got the shot.
Ah, I see. So the difference wasn't the vaccine, it was the underlying health of the groups being compared.
Exactly. It's like trying to judge the fitness benefits of joining a gym by only comparing the health of long-term gym members, who might be older or have joined because of health issues, with random young people on the street. You need to adjust for those baseline differences. Researchers use statistical methods to try and account for age, comorbidities, baseline risk factors to make the comparison fairer.
Right, trying to compare apples to apples. Okay, what's the next big one?
The next big one, and arguably one of the trickiest to fully eliminate, is confounding bias. This happens when some other factor, a confounder, is associated with both the thing you're studying, like getting COVID or dying, and the exposure, like being vaccinated. This confounder mixes up the results, making it look like the exposure caused the outcome when it might not have, or masking a real effect.
How would that work with vaccines?
Well, think about healthy user bias. People who choose to get vaccinated might also be more likely to engage in other health protective behaviors. Maybe they're more conscientious about wearing masks, avoiding crowds, eating well, getting regular checkups. They might have better access to healthcare in general.
Okay.
So if you just compare vaccinated people to unvaccinated people, the vaccinated group might look healthier or have better outcomes, partly because of the vaccine, but also partly because of all these other healthy behaviors or advantages. The observed VE might seem higher than the true biological effect of the vaccine alone because it's bundled with these other positive factors.
Like associating fancy cars with long life, it's not the car, it's the wealth behind it, allowing for better health.
Exactly that kind of spurious correlation. To isolate the vaccine's specific effect, researchers have to use sophisticated statistical techniques like multivariable regression analysis or propensity score matching to try and statistically control for these confounding factors like health behaviors, socioeconomic status, access to care, and so on. It's complex work.
Then you've got measurement bias. This is about systematic errors or inaccuracies in how outcomes or exposures are measured or reported.
Like how COVID cases were counted. Precisely. It could happen in lots of ways. Maybe misclassification of cases. A vaccinated person with only mild symptoms might be less likely to get tested, or their positive result less likely to be officially reported compared to an unvaccinated person who gets much sicker. This would lead to an undercounting of breakthrough infections, making the vaccine look more effective against infection than it truly is. Or you could have different testing rules or availability in different places or for different groups. Or just inconsistencies in how hospitals or clinics report data. Early in the pandemic, for example, testing was often focused only on people with symptoms because tests were scarce. Asymptomatic cases were largely missed. That made it really hard to accurately measure VE against all infections. Standardizing definitions for cases, hospitalizations, deaths, and having consistent widespread testing became crucial to reduce this bias.
Yeah, if you're measuring things differently in the two groups you're comparing, the comparison is flawed from the start. What about how things changed over time?
That brings us neatly to temporal bias, sometimes called time-varying confounding. This is all about the timing. The timing of vaccination relative to when the virus was spreading most intensely, which variants were dominant, and when immunity might be waning. As new variants like Delta and Omicron took over, and as booster shots were rolled out, the relationship between vaccination status and outcomes became much more complicated and dynamic.
How so?
Well, imagine comparing people vaccinated very early on, say in early 2021, whose immunity might have started to decrease by late 2021, with people who got vaccinated much later or got boosted. If you don't account for that time since vaccination and the variant circulating at the time of infection, your VE estimate could be way off. Some of those early studies hinting at negative VE might have been partly capturing this effect. If the vaccinated group in the study disproportionately included people vaccinated many months prior whose immunity had waned, comparing them to unvaccinated people at that later time point could make the vaccine look less effective or even ineffective in a crude analysis, especially against infection by a new variant. Researchers need to be really careful about when observations are made and how that lines up with virus waves, vaccine rollouts, and waning immunity.
Okay, that makes sense. Time is a huge factor. And lastly, what about people disappearing from studies?
Right, that's attrition bias, or loss to follow-up. This is a major headache for long-term studies. People drop out for all sorts of reasons. They move, they lose contact, they get too sick to continue. Sadly, some pass away. The bias comes in if the dropout happens differently between the groups being compared. For instance, if unvaccinated individuals who get severely ill or die from COVID are more likely to be lost to follow up in a study, the remaining unvaccinated group might look artificially healthier than they really are. This could skew the results, potentially underestimating the vaccine's true benefit.
Like that diet study example, if only the successful dieters stay in touch, the diet looks much better than it actually is for everyone who tried it.
Exactly. You need robust methods to keep track of participants, follow up diligently, and use statistical techniques like intention to treat analysis, where you analyze people based on the group they were initially assigned to, regardless of whether they completed the study, to minimize this bias. So all these potential biases, selection, confounding, measurement, temporal, attrition, they really highlight just how complex it is to draw solid conclusions from observational data, especially in a chaotic situation like a pandemic. Recognizing them and meticulously trying to address them in the study design and analysis is absolutely essential if we want to avoid misinterpretations that could have huge consequences for public health policy and vaccination strategies. Those findings of negative effectiveness, rather than necessarily meaning the vaccines failed, often acted as that critical canary in the coal mine. They signaled that these methodological issues were likely at play, demanding a much deeper, more careful, more contextualized look at the data. They were a warning that our analytical tools needed to be incredibly sharp. Vaccine safety, navigating reported side effects with context.
Okay, so beyond effectiveness, which we've seen is really complex to measure perfectly, there were also and still are really important discussions and understandable public concerns about vaccine safety. The sources you brought, especially that big National Academies report, they really emphasize that while the vaccines have been vital, worries about side effects are real, they're valid, and they absolutely need open, transparent discussion. So, what are the key takeaways from that authoritative report on vaccine safety, especially regarding the more serious concerns that got so much media and public attention?
Yeah, that National Academies report is incredibly valuable because it provides such a balanced, evidence-based look at the safety data. It absolutely confirms that yes, mild to moderate side effects are common. Things like soreness at the injection site, maybe some redness or swelling, feeling tired, headache, muscle aches, chills, maybe a mild fever, some joint pain.
The usual suspects after many vaccines.
Exactly. These are typically short-lived, usually gone within a day or two. And importantly, they're actually a sign that your immune system is kicking into gear, learning how to fight the virus. They're normal, expected, and show your body is building protection.
Okay, but what about the more serious stuff? The things that maybe caused more public alarm, got amplified online, and fueled a lot of debate.
Right. The report digs into those too. The most notable, and the one most thoroughly investigated, especially linked to the mRNA vaccines Pfizer and Moderna, is myocarditis. That's inflammation of the heart muscle. And sometimes pericarditis, which is inflammation of the sac around the heart.
Myocarditis definitely sounds serious. What are the symptoms people should know about? And crucially, who seem to be most affected by this specific side effect?
So the common symptoms, if it occurs, can include things like chest pain, often sharp or stabbing, maybe worse when breathing deeply, fatigue, shortness of breath, and heart palpitations, like a fluttering or pounding feeling. In rarer, more severe cases, it could lead to symptoms of heart failure, like fluid retention or abnormal heart rhythms. Now, the data clearly shows that the incidence, while low overall, appears significantly higher in males under the age of 30, and particularly after the second dose of an mRNA vaccine.
Okay, so a specific demographic risk.
Yes, the CDC and FDA actively monitored these cases right from the start of the vaccine rollout, collecting data meticulously. They did confirm a causal link between mRNA vaccination and myocarditis pericarditis, but, and this is vital, the overall incidence remains very low. We're talking rates reported in the range of about 1 in 5,000 to maybe 1 in 10,000 doses for males aged 16 to 30. And symptoms typically show up within a few days after vaccination. Most cases, importantly, were relatively mild and resolved with standard treatment and rest.
Okay, so it's a real, though rare, risk, especially for that group. But here's where that context becomes absolutely critical again. How does the risk of getting myocarditis from the vaccine compare to the risk of getting it from catching COVID-19 itself? because that comparison often got lost.
This is indeed the crucial context that completely reframes the risk-benefit calculation. Multiple large-scale studies, including a real important one in the Journal of the American Medical Association, JMMA, have shown without a doubt that the risk of developing myocarditis after getting a COVID-19 infection is significantly higher than the risk after vaccination,
How much higher?
often several times higher. Some studies suggest 7 to 10 times higher risk, or even more, of heart complications like myocarditis after infection compared to after vaccination, especially in those same young male groups. So while the vaccine risk might be around 1 in 5,000 to 10,000 doses for young men, the risk from the infection itself could be closer to 1 in 1,000 or 1 in 2,000 infections.
Wow, that's a huge difference.
It is. And that's why public health authorities, looking at this overwhelming evidence, consistently recommended vaccination, because it's a primary way to prevent severe COVID-19 and therefore also prevent the higher risk of myocarditis that comes with the infection itself. The fundamental message based on data is that the benefits of vaccination in preventing severe disease, including heart complications from the virus, far outweigh the rare risks associated with the vaccine.
That distinction is incredibly important. What about other concerns that were widely discussed? Things like blood clots or rare neurological issues?
The report also carefully assessed thrombosis with thrombocytopenia syndrome, TTS. This is a very specific, serious condition involving unusual blood clots combined with low platelet counts. This particular syndrome was associated with a different type of vaccine, the adenoviral vector vaccines, most notably the Johnson & Johnson vaccine. Now, while TTS is definitely a serious concern, the data showed it was exceedingly rare. Health agencies monitoring this found roughly 3 to 4 cases per million doses of the J&J vaccine administered in the general population. This rarity, combined with the seriousness, did prompt warnings and a temporary pause while more data was gathered and guidance updated.
Okay, exceedingly rare, but again, the context.
Again, the absolutely crucial context is that the risk of developing similar serious blood clots due to being infected with COVID-19 is substantially higher than the risk linked to the vaccine. Studies indicate the risk from infection could be tens or even hundreds of times higher than the vaccine-related risk of TTS. Similarly, Guillain-Barré syndrome, GBS, that rare neurological disorder where the immune system attacks the nerves, was investigated, also mainly in relation to the adenoviral vector vaccines. Some cases were reported post-vaccination.
How rare was that?
Very rare, around 1 to 2 cases per 100,000 vaccinations, which is only slightly above what you might expect to see normally in the population anyway, the background rate. The National Academies report concluded that a causal link between the Janssen vaccine and GBS remains sort of inconclusive, mainly because the numbers were so small it was hard to definitively say it exceeded the expected rate, but it's still watched closely. And critically, both TTS and GBS have also been reported in people who got COVID-19 infection but were never vaccinated.
So the illness itself can trigger these same incredibly serious, though rare, conditions, and often at a higher rate than the vaccine might.
That is the critical distinction, yes.
Yeah.
It's fundamental to any rational risk-benefit discussion. The sheer scale of the pandemic meant that even rare complications from the virus resulted in a large absolute number of people being affected. By preventing millions of infections, the vaccines actually significantly reduced the overall population burden of these very complications. And just to address some other widespread concerns that circulated, often driven by misinformation, the report is very clear. There is no evidence suggesting any of the COVID-19 vaccines cause infertility. That occurs. The only other adverse event mentioned, which is statistically rare and related to how the shot is given, not the vaccine itself, is shoulder injuries, things like bursitis or tendon issues if the injection technique isn't quite right. These are usually localized and get better with simple treatment.
Okay, so this comprehensive review really reinforces the overall message then. Despite these rare, serious side effects, which themselves are often much less common and less severe than the same problems caused by getting COVID-19, the overwhelming benefits of vaccination in stopping severe disease, keeping people out of hospital, and saving lives still far outweigh the known risks.
That's precisely the conclusion supported by the vast body of evidence when you look at it completely and with the proper context. It's a powerful confirmation of the scientific consensus on vaccine safety and effectiveness. 7. Policy implications and improving research validity.
Wow. This deep dive has really laid bare just how complex this whole landscape was, and how easily data could be misunderstood without that full context and a grasp of the research methods involved. The stark reality of the 2021 death toll, happening even with widespread vaccination efforts, forces us to ask some really tough but important questions. What are the broader policy lessons we should take away from this period? Thinking about things like lockdowns, mask mandates, and maybe most crucially, looking forward, how can we actually improve the integrity, the trustworthiness of public health research, especially as we brace for whatever future health crises might come our way?
Yeah, the fact that deaths increased in 2021, despite the vaccines and huge public health efforts, it definitely prompts some essential and admittedly challenging questions about the public health policies we use. For instance, we have to rigorously ask, were lockdowns effective, especially in the long term?
Yeah.
Look, those initial really strict lockdowns, they certainly slowed transmission dramatically. That was absolutely vital early on to stop hospitals from being completely overrun. They bought us incredibly valuable time.
But they couldn't last forever.
Exactly. Their long-term effectiveness clearly decreased as that compliance fatigue we talked about really set in. People just couldn't sustain that level of restriction indefinitely. Adherence waned, and transmission picked up again, even in places with strict rules. This suggests we need more adaptable, maybe more nuanced, and certainly more psychologically informed strategies for any future prolonged restrictions. Similarly, we have to evaluate mask mandates. Did they make a difference? Well, the studies largely suggest that masks, especially the better ones like N95s or KN95s, can significantly reduce transmission if they're used correctly and consistently by a large majority of people.
That's a big if.
Because their overall impact on the ground was definitely affected by fluctuating public compliance, the widespread use of less effective masks, and really varied enforcement from place to place. So their real-world effectiveness wasn't uniform, and the messaging around them often got tangled up in skepticism and politics. And maybe the most critical question for the future: how do we improve vaccine uptake and effectively combat misinformation? Addressing vaccine hesitancy isn't just about throwing facts at people. It requires building trust. It needs targeted educational campaigns that are empathetic, transparent about both the benefits and the aware risks, and that engage directly with trusted community leaders.
Building bridges, not just broadcasting messages.
Exactly. That kind of approach could significantly boost community engagement and maybe help achieve the high vaccination rates needed for strong population immunity against future threats. Asking these tough questions about past policies is vital for shaping more effective, more sustainable, and frankly, more publicly acceptable responses next time around.
This whole period really just hammers home the need for constant learning and adaptation in public health, doesn't it? It's not a static problem, so our responses can't afford to be static either.
Absolutely. The hard reality highlighted by those 2021 statistics, it points to significant gaps in our pandemic response framework. It demands really rigorous, honest analysis to figure out what worked incredibly well, like the lightning-fast vaccine development, and what didn't, like communication breakdowns, the struggles with compliance, and the fight against the tidal wave of misinformation. And a huge fundamental part of getting it right next time is ensuring the validity and trustworthiness of our public health research itself, so we can make decisions that are genuinely based on the best evidence and, crucially, so the public can have confidence in those decisions.
So how do we do that? How do we make the research itself more robust, more trustworthy?
Well, there are several key strategies often used together. The absolute gold standard for figuring out if an intervention causes an effect remains careful study design, especially randomized controlled trials, RCTs. RCTs are so powerful because they randomly assign people to get the intervention, like a vaccine or not, like a placebo. This randomization, if done properly with large enough numbers, helps ensure that both known and unknown factors, age, health status, behaviors, are pretty evenly distributed between the groups right from the start.
Taking bias out of the equation as much as possible.
Exactly. It helps eliminate selection bias and makes the groups highly comparable, boosting what we call internal validity. It makes you much more confident that any difference you see at the end is actually due to the intervention itself. Now, when RCTs aren't possible or ethical, researchers need to use the next best thing: strong quasi-experimental designs. These use clever statistical techniques, like matching people in the different groups based on key characteristics, or using methods like difference in differences to try and mimic the comparability you get in an RCT as closely as possible.
So really focusing on making the comparison fair from the outset.
Precisely. Another crucial technique is blinding. In single-blind studies, the participants don't know if they got the real treatment or a placebo. In double-blind studies, which are even stronger, neither the participants nor the researchers who interact with them or assess their outcomes know who's in which group.
Why is that so important?
It helps eliminate the power of expectations and unconscious bias. If a participant thinks they got the real treatment, they might report feeling better, the placebo effect. If a researcher believes the treatment works, they might subtly influence how they ask questions or interpret results. Blinding helps ensure the data collected is objective and reflects the true effect, unbiased by hopes or expectations. Beyond the design, transparency in reporting is absolutely fundamental for building trust and allowing science to self-correct. Using established guidelines like Consort for clinical trials or PRISMA for systematic reviews means researchers report everything about how the study was done, the methods, the results, in meticulous detail.
So others can see exactly what was done.
Yes. This allows other scientists to critically evaluate the study's quality, its rigor, its relevance. It helps others replicate the findings. And importantly, it helps fight against publication bias, that tendency for studies with positive or exciting results to get published more easily than studies with negative or inconclusive findings. A real culture of transparency means sharing all the results, positive, negative, or neutral, to give a complete picture. Also, using diverse methodologies, mixed methods, and triangulation can really strengthen research, especially for complex public health problems. This means combining quantitative data numbers from surveys, trials, epidemiology with qualitative data insights from interviews, focus groups, observations. For instance, a survey might tell you how many people are hesitant about vaccines, but interviews can tell you why, revealing the personal stories and beliefs behind the numbers.
Getting both the what and the why.
Exactly. And triangulation means using multiple different data sources or methods to look at the same question. If different approaches all point to the same conclusion, your confidence in that finding goes way up. It adds layers of credibility. And underpinning absolutely everything are ethical considerations. These have to be baked into the research from start to finish. Getting truly informed consent, rigorously protecting participant privacy, sticking to the core principles of doing good, beneficence, and avoiding harm, non-maleficence. These aren't just bureaucratic hurdles, they're essential for ethical research. And ethical practices also boost the credibility and trustworthiness of the research in the eyes of both scientists and the public. It ensures findings are obtained respectfully and reflect what they claim to measure, ultimately leading to better, more trusted public health decisions.
Wow. Okay, we have really unpacked a huge amount today. We started with that single surprising statistic about deaths in vaccinated people, then peeled back all those layers to understand the incredibly complex mix of factors driving things in 2021. We dove deep into what vaccine effectiveness really means in the real world, explored all those tricky biases that can mess with observational studies, and put the very real, though rare, vaccine side effects into crucial context. It's a lot to process, but so vital for getting a true, comprehensive understanding of such a critical time.
It really is. And the implications for how we talk about public health are just undeniable. Well, the complexities around COVID-19 data are huge, and while yes, there are real, though extremely rare, side effects from vaccines, the overwhelming weight of evidence consistently shows that vaccination was and remains an absolutely critical tool, especially for blunting the worst impacts of COVID-19, preventing severe illness, keeping people out of hospitals, and saving lives. When you look at the balance of risks and benefits with all the context rigorously, the data consistently favors vaccination.
What's the biggest thing that stands out to why you after going through all this again?
For me, I think it's just that powerful reminder. A single statistic, especially when emotions are high during a crisis, taken out of its full context, it can be incredibly misleading. It can cause immense confusion, maybe even real harm. It just hammers home how important critical thinking is, always digging deeper, seeking out comprehensive, nuanced information from credible sources. Looking beyond the headline to grasp the full, complex story.
I completely agree. And if we take a step back and connect this to the bigger picture, this isn't just about COVID-19. This whole period, it marks this pivotal, truly unprecedented moment in public health history. It showed us the incredible power of global science working together, the speed of innovation. But it also starkly revealed the immense challenges of communicating complex, evolving science in a world that's often polarized and operating under intense pressure. Moving forward, it just demands unwavering transparency from institutions, a real commitment to building trustworthiness and rigorous scientific integrity, all in equal measure. That's what we'll need as we face whatever public health challenges come next, so we can ensure our responses are truly evidence-based and communicated effectively to build public understanding and cooperation.
So as we wrap up this deep dive, here's a final thought for you, our listener, to maybe mull over. How might things be different next time? How might a deeper, more widespread public understanding of these sophisticated research methods and the potential for biases like the ones we discussed today, how might that change the way society reacts to future public health crises and how we all process the flood of information that comes our way? Something to think about, certainly.